So good morning and welcome everybody. I'm hoping you can hear me okay. If I'm on mute or something, could people please let me know. So it's thanks Sarah. Thanks. It's my privilege in many ways to introduce Wai Jia this morning. People have often heard me say that one of the best things about an outbreak is the people you meet, and Wai Jia is actually very much one of those people. And I just ask everyone to reflect back on the people they've met through the pandemic that they didn't know in 2019, but now actually they've got a strong relationship because of the work they've done together, or the circumstances that have brought them together. So I met Wai Jia when I was out at one of the large dormitories, and we realized that we really had no mechanism to communicate with all the foreign workers, the very people we were isolating, that we were giving instructions to, but actually not communicating them well. So the foreign workers didn't have a mechanism to really talk back to us, share their concerns, and I came across some cartoons. Wai Jia will remember the moment well, and I said, "Who's the cartoonist?" And of course it was much more than a cartoonist. It was a talented NUS graduate of medicine that was based in the Dean's office, and we started developing tools to communicate with the foreign workers, both what was coming up, what were their concerns, why we were doing things, why everyone was having tests and then half of them were being taken away the next day in a bus. No, they weren't being sent home. It was all about managing the pandemic. And this was a wonderful relationship that evolved. Now, as many of you might know, that until recently I was chair of the Global Outbreak Alert and Response Network, and one of our mantras is understanding the core components of an outbreak response. So everyone's aware of case management, everyone's aware of the need for laboratories, for infection control, for maintaining mental health and well-being. These are all components, and this all needs to be coordinated and have strong leadership, and Singapore was very good at pulling all this together. But the one thing that's often forgotten about is what we call risk communications and community engagement. And this is where we communicate with a population, where we listen to a population, where we provide communications through a number of different modalities that has to be consistent, that has to be relevant, that has to be accurate. And this is very much the challenge in an outbreak, is getting that communication right. And Wai Jia walks the walk and talks the talk, and has shown herself to actually become an international leader in this. And recently she was asked to go to Eswatini, a country that probably many of us haven't even heard of, but to go there and further develop through UNICEF and through GOARN and through WHO, develop this risk communications and community engagement in this moment, particularly relating to vaccine and vaccine hesitancy. So that brings us to what today's all about. Is Wai Jia is going to share this experience with us, talk about the technical aspects of risk communications, community engagement in a particular cultural context, but also share with us her personal journey in going and doing that. I know she's very grateful to the School of Medicine and Chong Yap Seng who supported her through this, and she was away for 6 weeks doing work which I can tell you now is lauded in Geneva. So with that, I'll sit back and look forward to hearing what Wai Jia has got to say. Thanks.
Thanks so much, Dale. Thank you, Dale. So good morning, everyone. Thanks for being here bright and early. My name is Wai Jia, and today I'll be presenting to you what happened when I was deployed to Eswatini earlier this year, and I've entitled the presentation Vaccine Hesitancy and Lessons from the Frontline. So just to give you a brief introduction of who I am. As Dale mentioned, I work at the Dean's office, and during the outbreak, I founded my brother SG, which really is a network of different organizations that supports the health and well-being of low-wage migrant workers in Singapore. And since then, I joked with Dale that my life has completely changed since that moment in the outbreak when I met him and he thought that I was a cartoonist. But late last year, Professor Dale had actually forwarded me an email that was from GOARN, WHO and UNICEF, and they were asking for people to be deployed really into Africa. And when I first got his email, when he said, "Are you interested?" the first thing that came to my mind was, "Are you crazy?" The first place they didn't specify, which country it was, and it wasn't certain how long it was, although they said a minimum of 6 weeks. And these were the people I would have to consider leaving behind. So that's my husband, my two kids. They were aged 4 and 2 at that time, and I thought to myself, this is impossible. There's no way I can leave them at this stage of my life for 6 weeks. And even though it was a dream that I had since I was a medical student, but when the time actually came, interestingly, I just pushed it to the back of my mind. I told Dale, I wish it was closer. Maybe in Asia, I would consider it, but this is going to be to Africa. I don't even know where it's going to be. There's so much uncertainty. My first reaction was no. And later on, as time passed, I realized that I couldn't leave that stirring my heart any longer. And what happened was that as I continued to think about it, I actually asked my husband this question. I said, "Do you think I can go?" I forwarded the email to him finally. And interestingly, when I shared it with my kids, they didn't think it was such a crazy idea. And so Sarah Faith, I am a little embarrassed to say this is a Chinese assessment book for a 4-year-old, but she started drawing a plane and she drew my family inside the plane. There were 4 of us. And then she said, "Mommy, you are going to Africa." And she said, "Daddy, Mei and myself, we're going somewhere else and we're going to go have fun." And so as she said that, what really struck me was the need for me to return to the call of my heart, which was really, to have the opportunity to work with developing countries and vulnerable communities. And that was then I remembered the dream that I had when I was 17 years old. When I applied to medical school, really it was to do humanitarian work in developing countries. And so I said yes. And as soon as that happened, the objectives of the mission, were all sent to me. It's a little overwhelmed. I know it's a busy slide, but it just gives you an idea of what was required of me. Really, it was to strengthen risk communication, community engagement among different stakeholders in the country, providing technical support. For those of you who are not familiar with RCCE, really, I tell people in a nutshell, it really is health messaging, but health messaging in so many ways, understanding the community, being responsive, being on ground, making it two-way. So there are lots of different components of it. And of course, enhancing capacity building in terms of training, providing curriculum to the different on-ground partners, even people who really work in the rural communities, like rural health motivators, and hearing their feedback about the myths and the different kinds of rumors that were going on in the community. Very quickly, I was given key expectations about effective technical assistance needing to be provided, etc. But what I didn't share with you was that the first time they informed me that I was to go, when I finally said yes, I was told I was supposed to go to Congo. And then I had this huge shock of my life, because after taking this huge leap to say yes, I thought to myself, okay, I hope they send me somewhere, that's okay. And when they said Congo, I guess it was a shock to me. Thankfully, though, I think that kind of gave me, set the expectations for me as to what I had put myself into. And when I said yes to even that, 2 days later, when they said, you don't speak French, it's probably not a good fit, and they would redeploy me, they'll find a better match. When they said it was Eswatini, like what Dale said, I think many of us don't know the country, but it was easy to say yes when they redeployed me. It was a 6-week deployment. Honestly, when I was there, I wasn't sure what to expect. All I knew was that I was going to say goodbye to my family and suddenly change my identity from being a lead here in terms of the migrant worker work and a mom to over there being a RCCE UNICEF consultant. So I really thank Dale for forwarding that email that changed my life. But Eswatini, this is just to give you an idea of the landscape. The topography is really beautiful. It's breathtaking. It's a really tiny country at the border of South Africa, and it's a population of 1 million. So it's low rolling hills all around, beautiful place. It feels like air conditioning all the time, even outside. So the background of the country is that when I arrived in the place in January, 38.8 were fully vaccinated. And we had to look at some of these statistics and really come up with a plan for the country. And as you can see, those who are 50 and above really have the best vaccination rates. But those in the lower age groups have very poor vaccination rates. And even among healthcare workers, they were stagnating at about 80% were fully vaccinated. And so we highlighted 3 vulnerable groups. The priority groups were the vulnerable elderly, because we want to make it as close to 100% as possible. Health workers, because they are high risk, and a large percentage of the youth were actually very resistant to vaccination and actively resisting vaccination. So that was something that we felt we needed to look into. And so the objectives were really to improve the vaccination uptake among all these different groups. So the assessment methodology that we went about was using quantitative, qualitative assessments. The United Nations had this series of surveys called the Behavioral and Social Drivers Survey. So I adapted it, contextualized it for Eswatini. And they also have something called U-Report, which was fascinating to me. It's really a phone kind of poll that they put throughout the country, and they were able to do this for all the regions in Africa and do a comparative kind of study. So that was really fascinating. But so as you can expect, the people who actually use the U-Report are really young people. And so there are all limitations and constraints in different ways. Now, the outcomes, I would just love to share with you a glimpse of it. I won't go into great detail, but these qualitative kind of interviews just brought me all over the country. You know, I was traveling to the rural outskirts, spent a long time, you know, traveling to these really far-flung villages. And as you can see, I'm in my UNICEF vest and something called a lehia, which is a traditional wrap skirt in the community. And if you're a woman, you really have to respect their culture by dressing as they do. And so what you see in the first picture is actually called an Inkundla house. So that is actually like almost like the community club equivalent in Singapore. So we have CCs here, and we have these Inkundla kind of houses where the village chief and the people would come and gather. And so we gathered them and we did focus group discussions with the elderly people. As you can see in another place, this was actually one of the lowest uptake in Kundlas, which is a village that we visited. And interestingly, due to the political climate of the country at the time there was a lot of resistance when COVID-19 happened. There was some political sensitivities that were going on at the time, and so people related the whole vaccination exercise, the whole COVID thing, as almost like a conspiracy. So this particular village had a lot of strongly held beliefs about that. And so it was really critical to understand that political climate before we actually went into design programs. Over here in this picture, you see a very different profile. The first picture is really youth champions. So this is like a super segmented kind of population. They're not only youth, but they are youth champions for sexual and reproductive health. They are already very sensitized, and they were giving great ideas about how to actually share COVID-19 messaging and vaccinations among their peers, because there are plenty of programs that we can write on already. And we'll share a little bit more about how that snowballed to some programs that we recommended. And in the picture below, you can see that we went also to the rural villages to speak to the youth over there. Many of them, as you can imagine, are unemployed and not going to school. And they shared with us many of the myths and the rumors that they were believing. Now over here, they are rural health motivators. As you can see, many of them are jajas, meaning they are grandmothers of the community. And they really are the hands and feet of health messaging. They really go out door to door, literally crossing rivers and going through hardship just to get to different people in the community. And they are just so driven by their passion for the people in their lives. So just to give you a glimpse of all these pictures and what we found out, basically there were a lot of similarities, such as beliefs in the fact that the vaccination had things to do with, some sort of a political agenda, but also that many of them strongly believe that the side effects were something that were difficult to manage. For example, something that's very simple to us, like taking an MC. This is actually crucial for them because they don't have the ability to do that. So going for vaccination might mean losing 2 to 3 days of wages, which is critical to them. It might mean traveling long distances out into to a health facility. It might mean plenty of other things. And so it was really important to have these conversations with people. So as you can see here, this is the BESD, the Behavioral Social Domain kind of qualitative survey that we carried out. And the results were grouped into 4 different categories: really thinking and feeling, understanding people's confidence, risk perceptions, trust, their motivation, their social processes, whether it's driven by peer pressure, and then practical kind of considerations as well. So just to give you a sense, people would say that it's too far from the health facility, or it's expensive, or there are long queues. So just imagine this, that for us, we can access a health facility really easily, or it comes to us. Whereas efforts to station like a vaccination van, for example, even that encountered several difficulties because people would be out in the fields or out in the factories working. And by the time they came home in the evenings, the van would be gone as well. And so the recommendations were really to be able to reach people at their workplaces, like in the factories, for example, or having the vaccination vans come after office hours. So there was a lot of coordination issues as well, which I'll share in a bit. But just to give you an idea that understanding the context was really key to implementing some of these health recommendations. So one of the key things that we noticed was that the need for training health workers was really important with vaccination information. There was a lot of rumors in particular about the side effects being so grave that people would die. And these were spread via word of mouth through the villages. And they were very, very believable because these were people that people knew or people's friends knew. And there was a need to partner with the village leaders. Previously, you saw a picture with us in the Kundla office, like a community club. And that was really going down face to face to speak with the village chief, whom was really resistant to vaccination at first, actually changed his mind and then invited the whole UNICEF team to come down and do sensitization. So that really goes to show you how granular community engagement can be. We also did that at a regional level and engaged different stakeholders. And also looking into improving service experience, providing access to vaccination, all these were really important components. So as you can see here, the village chief is the one, you can guess where he is. He's dressing a little differently. He's actually next to me, probably I'm more obvious. And he's wearing this animal skin that's hanging out from his belt. So that's the village chief, that's the traditional attire of village chiefs. And he was the one who had several reservations about vaccination. And after this engagement, he invited us to come down. And so this was used as a pilot model in terms of engagement, but also in terms of how we did the resensitization. It was really important to do 2 things in a coordinated way. One is called social mobilization, where we get the people themselves to spread by word of mouth. And secondly, to actually organize the vaccination van to come down. And even this whole coordination really occurred in a context where several moving parts were taking place. So I'll share with you in a little while later how all that comes into play. But for this, in Kundla, this village, it was very different. We actually had one woman who was a rural health kind of motivator from World Vision. She was very, very, motivated for the vaccine. She herself had gotten vaccinated, but everybody else in this group was very resistant because of the political issues. They were on the, they were facing some challenges with regards to the village chief, etc. And so there was a great deal of resistance. And it was not easy sometimes to make the call to say, how we would strategize actually targeting in Kundlas or villages like that. Just to give you a sense as well, some of the issues that people kind of struggle with was really lack of confidence. And I think this, helps us to really be grateful for what happened in this side in Singapore when the pandemic broke out, and there was a lot of up-to-date information that was being given to us, almost in real time. But in Eswatini, it was challenging for people to get that kind of information so quickly. And so what people told us was, you can't tell how you'll fare in the long term. And there was also this idea that the donated vaccines were of a poorer quality. So people would say, this is the first freebie we've ever received. Why should we believe it? When we looked at social norms also, we thought that, peer pressure might play a huge role. But interestingly, across all age groups, people actually said that it was a very personal choice. Even if their friends did it, they wouldn't do it. And they wouldn't even trust if, let's say, a celebrity or an influencer promoted it, because there was such a strong belief in this national agenda to vaccinate everybody. And so there was a lot of resistance towards that. And so that helped us kind of understand the context in which we were working with. So for example, for youth, what we discovered that would be really helpful for them was to provide safe spaces for that dialogue. So more of like a micro setting to dialogue. But of course, the digital space is huge. And so just before I left, we were in the midst of talking about, youth programs digitally, videos that would, kind of capture these kind of difficult FAQs that were being answered, asked by youth and then answered by health workers. So that was something that we looked into. And also peer education. So that was what those sexual and reproductive health youth champions had suggested. Then there was also this idea of social media, asking real young people, average young people, not like celebrities or influencers or anything like that, but really just real people asking real questions, and that went down very well as well during our focus group discussion. But with regards to practical issues, I think we covered that just now about having the vaccination van station long enough so that it didn't interfere with people's work or school. But what I think was most strategic that we did was to form this local steering committee of key youth stakeholders. And again, this model was really taken from the time during the pandemic here, when Professor Dale had mentored me. And during that time when the migrant worker outbreak had broken out, he was really the one behind the idea of galvanizing all the different stakeholders to get together on a regular basis. And so that was what we did. This is me together with the local leaders, coming together, all the different stakeholders that you can see who were involved in some form of youth work. We came together and I shared the findings with them, and they in small groups came up with different strategies that they would deploy and in their own organizations. And because there were cross-organizational discussions, they also look for ways of synergy. So what you see over here is our youth champion training. Each of those organizations that you saw earlier, they nominated youth champions from each of their organizations. We came together, we did a training. So this was a training that I co-developed actually from a module that I had come up with in Singapore during the vaccination effort. At the time, there were certain faith groups that had a lot of resistance. And so we came up with a campaign called Speak Truth in Love. If you are interested, it's stil.sg. And from there, we used those principles of navigating difficult vaccine conversations to train the youth. So you can see there, they're doing role play actually about how to answer difficult questions if their friends challenge them and mock them and put them down for getting vaccinated. How do they actually kind of respond to that? And that was very, very well taken. If you can see in the picture, some of the young people, they were also very receptive to my partners. So one of my partners was, he's an Eswatini consultant with the WHO, and he was able to contextualize what I developed to the local context as well. So that was really a lesson in terms of partnering locals and not just us, flying in and telling people what to do, but really working together with the locals to move things forward. So that was very, very exciting for me. Okay, last bit, challenges with coordination. Now, this was not easy because there were communication issues between the Ministry of Health and the different non-profits. So very much it was non-profit driven, but the problem with that was that then vaccination vans from the Ministry of Health and the non-profits would be uncoordinated. So both might show up on the same day to a place, or one might go just, a few days between each other, and that would really be a waste of resources. And so that was difficult. There was also issues of lack of transport and lack of manpower, lack of resources, lack of even very basic things like documents, etc. And so there was a sense from health workers when we interviewed them that there was a huge sense of a loss of control. So many of them shared that we were expected to perform to hit these vaccination targets, but with no support. Many of them were burnt out, but they gave great suggestions like centralizing the communication strategies, as well as adopting this clear, centralized kind of communication from MOH to the non-profits, to the health organizations. And so over here was one of our key strategic meetings where these are all senior stakeholders from the Ministry of Health as well as UNICEF, and we presented our findings to them. And so we could see that with regards to vaccination work, it's very much on ground, very, very hands-on, face-to-face, but there was also high-level work done in terms of advocacy and trying to get buy-in from stakeholders. So the recommendations I will summarize. Vaccine differentiated measures, it may seem something that's very obvious for us here in Singapore, especially when I think restricted measures were implemented for dining. I think that was really like a huge boost for us, but also I think in Eswatini's context, travel incentives were perceived to would be a huge push because people loved to travel outside of Eswatini to South Africa at the borders. And so that was suggested, mandatory vaccination for high-risk groups as well, adjustments in service delivery, like delivering vaccination at the work sites, as well as having centralized coordination for health worker communication. These were the key policy recommendations we gave to the ministry when we met them. And for the regional leaders, they're on a different level. And so we kind of had to go down to something more granular, like planning the social mobilization and vaccination schedule. So really, really looking at schedules, training them to explain the information, very granular, very different level, increasing the access of vaccination, even on weekends or after office hours, and to pilot at number 3, you can see Kuala Seni in Kundla, which is the name of that low uptake village, and to replicate that success. When I left, it was the end of 6 weeks. It was very, very short. I felt like it went by in a flash, to be honest. And at that time, there were also efforts to kind of engage the national radio and media campaign. There were some efforts during the acute phase, and then the partnership died off. And so there was really plans to re-engage them in a refreshed way, and then strengthen the engagement with the youth LSC stakeholders, which is the local steering committee. And so the updates today, just to give you an idea, so it's been a couple of months since I've come back. This is a busy slide, but I just want to summarize in that some of the recommendations were carried out mostly in terms of hitting the regional kind of leaders, in terms of mobilizing people, resensitizing, reactivating stakeholders. And there's also a lot of efforts being put into integrating COVID-19 vaccination into the mainstream health services. And then there were also lots of efforts to engage with school health programs. I think that was probably the most successful one. However, the team reported back to me they shared with me this week that there was not much progress on the ministry advocacy front. So those are the constraints that they face. And that is the context that they have to live with in terms of struggling with kind of different stakeholder motivations. And so I think it was important to kind of be sensitive to that and then suggest recommendations that would really help to move things forward. All right, now I'm at the last leg of my presentation. I'm going to highlight some mission highlights and successes. This is probably my favorite part. I guess the challenges would be struggling with what I shared with you, to a certain level, a certain degree, disengagement from the ministry or a lack of centralized leadership. However, there was a lot of, I think, great things to learn from the UNICEF team and different non-profit stakeholders. The kind of spirit that they continued to hold in spite of these challenges was really admirable. Some of the highlights, as you can see, were really meeting the village chiefs and the regional stakeholders face to face. Now, on the right-hand side, you can see a very tall, broad man who's wearing like some sort of like a Nigerian outfit. He was actually the Eswatini consultant that I worked closely with. And it was fantastic because he really understands the social context. And for me as a young lady, really, I don't have the social capital, so to speak to elderly African men, but having him in the picture was really helpful. So both of us really worked as a great team together. And so team chemistry was something I was very, very grateful for. I love this picture. These two were actually taken on my birthday. I spent my birthday in Africa, in Eswatini. I think that was why this particular trip was so special. On my birthday, they had organized, of course it wasn't planned, but they had organized, about 80 rural health motivators for this training course. And the women that you see in yellow, they are really outstanding. I feel they epitomize community engagement. The story goes that there was a woman who had COVID-19, and she suffered so much trauma emotionally, psychologically, and even physically, from her whole admission process to her discharge, and from coping with the stigma in her community, that she decided to start this movement called COVID-19 Survivors on the Move. So that's the name of their so-called little non-profit or their little initiative. And they were so successful because this woman galvanized other village women and even professional women together. They did training among themselves to educate themselves and their friends about, COVID-19, how to cope, and how to cope with the stigma, what it's like to recover. They taught their other friends, and what they did while we were there was actually they got a van that was sponsored to them, and they started to go to the low-wage factories where there are thousands and thousands of low-wage factory workers who are working there, and they would go there to give talks, like motivational talks, like inspiring talks about how they got vaccinated, their own experience, telling people that it's not worth it to get COVID. And then right after that, they would have a vaccination van right there. And so how this all happened was that this was just a woman. It was just a woman who decided, I want to do this. And she just started making calls to factories herself. And then after that, she was so entrepreneurial. She got sponsorship for her van. And then later on got people to, from the ministry or from non-profits to come and set up the vaccination van. So all this from one woman. She works at like the tax revenue agency. She's amazing in terms of galvanizing community. And so that really was one of the highlights of my trip, to see how community engagement really can be and should be done from the ground up level. So I wanted to share that with you. All right, this picture is very special to me. This is Nomi, and we joke that she's like my Eswatini mother, because she was not only my team lead, but she also looked after me extremely well while I was there. One of the things I benefited from, the reason why it was successful, was because really I flourished under her excellent leadership with the team as well. There was a lot of professional and social networks established that I could easily jump onto. So really it was great. And even before I had embarked on the trip, we were making calls, learning the language. And I think that was really important, this sense of cultural assimilation. This was the birthday cake that she had done for me. That is the biggest birthday cake I've ever received in my life. But that is the Eswatini flag that you can see. And below is the name Busi. And Busi is the short form for Sibusi Siwe, which is what they called me throughout my whole trip. So it was quite funny because people were starting to take my number down, like my WhatsApp and things like that, or write emails. And it would be recorded as Sibusi Siwe, and that's what they called me. So I think culture, you can see here, this is proof. They would CC me in all these emails and write my name as Sibusi Siwe. And I asked them, I said, why did you name me that? And they said, Sibusi Siwe literally means we are blessed because of you. And so that really encapsulates, I think, the gratitude and the warmth of the people. Previously, my husband and I had spent a year in Uganda before volunteering and serving, but this was, really friendship at a whole new level because we only had 6 weeks. And so this is me and the UNICEF team and all the different people who looked after me and made sure that the mission was a success. These were the various send-offs, the 1,001 send-offs that people did before I left. This picture is probably the most memorable one for me. That's me, as you can see, in the UNICEF vest and the traditional lehia. And I would, if I had to kind of summarize my entire experience, it would be that it was a professionally fulfilling and rewarding experience. I'm really grateful for the support that Professor Dale and Professor Chong Yap Sing gave to me to even embark on such a trip, to take 6 weeks off my work here, to be able to contribute to something on a global level. I'm going to end off with one last anecdote, which is this. On the last day before I left Eswatini, I had asked myself whether this entire endeavor was worth it and whether any fruit would be born out of it. And interestingly, my neighbor downstairs, from where I stay in Singapore, she did not know it was my last day in Africa. But on that day, she sent me a photo of this. And it was a sunflower, and she said, "This is the plant that your daughters planted just before you left, together with my son." And she said, "Today it has bloomed." And when I saw this picture, I just had goosebumps because to me, it was such an amazing picture of the fruition of what had come to pass. And when I saw a picture of this together with my children, I think what came to my mind was really this quote, "What we sow in tears, we will reap in joy." And so I thought about the different things that we had to leave behind, but ultimately it was such a fulfilling experience. And so I come to the end of my presentation. I want to thank all these different partners and also want to thank you for being here, for listening. And most of all, my hope is that as you have listened to this, that it will also inspire you to take the step of faith when the call comes for you to step out and make a difference. And as someone who has been there, I just want to encourage you that it might seem impossible at first, just like how I had said no, but when you say yes, it is ultimately rewarding and it is ultimately fulfilling. So thank you all so much for being here on this early morning, and thank you, Professor Dale, for making all of this possible in the first place. Yeah, thank you all.
So thanks, Wai Jia. We've got some time, I think 7 minutes for questions if I can see any hands up, and these could be questions about the technical side of the mission or the logistics side of the mission or just the personal side of the mission. Please feel free to ask something. As I kind of mentioned, this is how GOARN works, is that out of about 270 partners, of which NUH is one, we send experts to the field to slot in to national efforts, and these come about when a country actually requests some help to get an expert along. So I guess, Wai Jia, two questions. It's all about sustainability, and you can do six weeks great work, but what would you say is the leftover basically at the Eswatini end? What have you left behind? I think that's a sustainable improvement. Mm-hmm. And personally, what do you think you've gotten out of it apart from a great 6 weeks? How have you grown personally, would you say, professionally?
Thank you. Okay, so there are two parts of that question. The first one was about sustainability. Thank you, Dale. And I think that was a huge question that was on my heart. And so I think the greatest lesson that I learned during my 1-year service in Uganda is that whatever you start alone, you will end up leaving alone as well. But whatever you start working on together, you will end up creating longevity for that. And so what I was really grateful for was that throughout the entire process, I had the chance to work with the local leads of the various aspects. So even when the local curricula was developed, for example, it was really, in a sense, co-developed and then contextualized together with my consultant from Eswatini. And so he really brought such a local flavor to this training program, which was talking all about conversations with people, how to answer difficult questions, and just having that local flavor and his input really helped them own the program. And so I think those aspects of the mission were more sustainable. So up to now, they are developing that, they are sharing that. The list of FAQs that I left behind, Q&A for the different youth stakeholders, they have taken that on and shared it with the school program leaders. And I felt what my role really was not so much to be kind of like the hands and feet or the leader, like telling people what to do. But I think the key word for me was just remembering that I was there to be a catalyst. And I think that metaphor is very rich in a sense. A catalyst is very small, as we all know in chemistry. And so I think the attitude of humility was important. And the fact that we are not there as main ingredients, but we are really there to catalyze something. And so I think that was the key thing that helped to build sustainability. Yeah. And the second question, Dale, what was that again? Sorry.
It was about you. What's sustainable in your professional development?
Wow. Okay. Oh, that is huge. I think the thing that left the biggest impact on me was being able to find my identity in terms of a professional kind of capacity. So as this is probably a little bit more personal, but I think many of us go through life in our profession as our identity as health workers, but sometimes not really fully finding our fit. So there's always, we all do different jobs, 101 jobs, but when you find yourself stepping into something where you're in the zone and everything comes to you so naturally, I think that's when you really come into the fullness of your identity. And what this trip did for me was help me to identify the strengths I already had and to continue to hone them for something that was greater than myself, something beyond the shores of Singapore, and to actually be able to crystallize that into something tangible. I think that for me was life-changing. And what I will bring forward from that is to continue to have this global outlook. Somebody shared in the chat, are you planning to expand to other rural areas? In this one, it would probably have to be replicated by the locals, but in future opportunities, I think it would definitely be easier to say yes again, and also continue in terms of teaching and research and encouraging other people to do the same. So that was my greatest takeaway.
Well, for someone that was scared of the question, I think I'd also add that you've become a lot more articulate.
Thank you, Dale.
Okay, so I think you answered the question from Joanne Lim as well. So there's no other questions that I can see. So I think we might close out. I believe everyone listening is inspired by seeing what someone that's based in little Singapore can do and have a global impact. This is certainly something that I'd encourage. I'm not hard to find if you're interested in this or any type of deployment work. There are opportunities in. It doesn't have to be COVID vaccinations. I know Darius is currently doing a dengue outbreak also in Africa. So
thank you. And I'll also add on, if you don't mind, I've shared my email and my IG on the chat in case some of you might have personal questions to ask me that you're too shy to ask here. You're welcome to reach out to me and I'll be happy to take questions.
Or indeed wish to get involved in risk communication and community engagement in Singapore. It's Wai Jia is always looking for
new adventures.
Partners. So thanks everyone. Have a great end of your week and a great weekend, and thanks for tuning in early this morning. Thanks.
Thank you everyone.
Thank you for watching. My hope is that every message on Kitedreams will inspire you to dream bravely and live boldly for God. If you've been blessed by these messages, feel free to share them with your friends, subscribe, and I'd love to hear from you. May God grant you the courage and faith to pursue all that He has in store for you. Be blessed.